What is up, you C. diff sailors?
Ooh, dirty.
Welcome to another episode of 3 PTs in a Pod, episode 8. We are doing a article review this week. We are going to answer a listener question, and we are going to wrap up the show with answering a PT 365 question. All right, guys, welcome back. We are at episode 8 now. Welcome. Thanks for joining us. Got a big episode today. A little other additional piece of business. Shout out to us. We are now part of an accredited program, Alvernia Physical Therapy. If you go on CAPTI's website, I believe we are the first program listed now. So all about marketing,
Look at that.
AA Alvernia. So we're number one on the
Till
list.
AA Ron University gets a credit.
So anyway, shout out to us. I think the three of us were probably three of the biggest pieces of that puzzle for the program becoming accredited. I think if you really, narrow it down to the reason we became accredited and what was behind it, the three of us are kind of right up there. Yeah, exactly.
Nobody else.
No one else.
Legitimize the program.
Yeah, I mean the hours of blood, sweat, and tears that we put in to become accredited.
Put the name on the market.
Yeah, put the team on our back. So shout out to us, shout out to the program. We're accredited now. We'll get to actually make some money doing this.
We can
When we get done
graduate.
school, we can graduate. So it's all good. All good. So this week we are going to get started, guys, with another article review. Article that we are going to look at this week is titled Veteran Experiences Seeking Non-Pharmacological Approaches for Pain. So this is a very recent qualitative research article, 2018. It is from the journal Military Medicine, from the authors, let's see, we've got,
Good luck.
yeah, Carleen Giannatrapani. She's a PhD. Shout out, Carleen.
Pretty huge dick she got.
And then a bunch of others. So we'll say Carleen et al. If you want to look up the article, we'll try to post a link to it so you can look it up. But that's the journal it comes from. Yeah, a couple of PhDs on the team here. So really interesting article. Just wanted to kick it off with just mentioning a couple things. I think it goes in with the theme of us recently having Memorial Day. So looking at veterans and those who serve our country in the military. So that's and I am actually using this article for our qualitative research class we're taking this summer.
Just do all the work for
you. So I kind of killed two birds with one stone there, but I thought it was a really interesting article. Thought it would be good to cover on here, and I also thought it could maybe transition us into some discussions maybe in other episodes about pain science and pain management, pain education with patients, because I think that's a big area that's starting to become more recognized now within the physical therapy sort of field, and it's an important thing to talk about and something that we don't necessarily get a lot of in school, although shout out to our professors. They have mentioned some stuff relating to pain management, pain science, some of the more recent stuff coming out about that. So let's get into it. I'll give sort of the basic rundown of what the article, kind of the methods, background, all that stuff. And then I think the main thing is we should kind of talk about the major themes that came out of the interviews that they did. So there's 5 major themes, and we can just kind of build most of the discussion around those. So number 1, it's a qualitative study. A lot of people might not know what qualitative studies are.
4 weeks in.
Yeah. 4 weeks into our summer class on qualitative research, and I think so far we can confidently say qualitative studies are about words. So
Not
a lot of
just to get the numbers.
No numbers in qualitative studies or research. A lot of word-based research that goes on with the qualitative studies. So mainly looking at more of the subjective experiences and phenomenon of certain things that go on within the field of physical therapy, whether that's through patients' perspectives, therapist perspectives, etc. So that is what we're looking at with this study. The purpose, the authors said, was to identify and understand veteran perceived experiences with and barriers to complementary non-pharmacological approaches for pain. So they wanted to get an idea of actual experiences of veterans that are dealing with going through the process of trying to get things done for their pain that are non-pharmacological in nature. And the authors made a point in the beginning of the article to say that there really aren't that many studies out there specifically giving the actual experiences and like words from veterans. So it's sort of something that hasn't been done too much yet within the research. Their methods, so they collected data as basically on participants as part of a more bigger overall research study that went on from 2012 to 2017, which was called the Effective Screening for Pain Study. That's where they recruited their convenience sample that they used for their participants. Inclusion criteria. They had to be military veterans waiting to see a provider for a visit where vital signs would be taken. As we know, the sixth vital sign is pain. So because they took their vital signs, pain was included in that. They had to be capable of reading and answering questions rationally. So they didn't want any like cognitive impairments in participants. They could not participate in the study if they had no working phone. It's a big part of being able to take part in a
What about a
phone
pager?
interview.
That's a big catch-up.
What about a pager? Could they use that?
Pager, I don't know. That's maybe further research, another research study based on only people with pagers. And then hearing impaired and unable to complete the phone survey also. Those individuals, unfortunately, were not able to participate. So they use to collect the data semi-structured phone interviews. I believe we just talked about semi-structured interviews yesterday. Don't ask me what
Did
that
we?
is yet, but that's what they used. And those phone interviews were audio recorded and professionally translated. They had, so participants, 36 veterans total, 29 male and 7 female. The age range was 28 to 94 years old, so quite a range.
It's like a World War II veteran.
Yeah, probably, yeah.
Shit.
So that's pretty interesting. And pain scores, so they did a numerical rating of pain basically as part of the interview and part of the interviewing process. Pain scores range from 0 to 9 amongst participants. There was a 3-member team of investigators that evaluated the transcribed interviews, and using the method of constant comparison, they determined resultant themes that came from the questions asked to the veterans about their experiences with trying to get non-pharmacological treatments for their pain. There were 5 major themes that emerged. I'll just quickly run through the 5 and then I'll stop talking. So I've been talking like the whole time, and kind of we can go one by one and we'll see what we thought about each one. So the 5 major themes that resulted from these interviews with the veterans regarding their experiences. Number 1 was provider communication about alternative pain approaches. 2, care coordination for alternative pain management approaches. 3, veteran expectations about experiencing pain. 4, veteran knowledge and beliefs about non-pharmacological approaches. And 5, access to non-pharmacological approaches. So let's get started with theme 1, which was provider communication about the alternative pain management approaches. What do you guys think about that, or any big takeaways from that area?
Yeah, I think the first interview that they wrote in was actually really interesting, because you have the veteran talking about how he was the one suggesting things like physical exercise. So like one of the sentences that he said was, so even if I'm in a lot of pain, can we do some physical exercises? And then he goes into like stuff that he could do, like lifestyle changes. So he asks if he should get a new mattress, if it's painful at night, or a new sofa because it's painful to sit, or a new desk chair at work. So like he's trying to think of alternatives to the painkillers, and I think like, you know, it's not like they're not open to doing something else. Like
Right.
they want to try something else because there are side effects to the painkillers that they're taking. You know, so you have the doctors or the PTs or whoever have to know that these people don't just want the pills and like want to go off on their way. They want to find an alternative that'll make them feel better without having all these side effects of the drugs. So I
Absolutely.
thought that was a really great intro into like the patient interviews.
Yeah, I actually had that highlighted as well. That
Same.
the physical exercise
Mm.
that was a good point. Yeah, and I think the overall point that the authors sort of made about theme one was that what specific communication from the provider about the alternative approaches was like a key factor in whether they did try it or not. So that's a huge like role that we play. Like you have to make that initial effort to communicate that there are alternative approaches. Some do know about that or do want to try their things, but you do have to, you can't assume either. You have to make sure that you at least make it known that there are other options out there. And obviously you're not going to step on the toes of the doctor if they're prescribing medication, but you could also mention to a patient, like maybe in conjunction with this, we try one of these alternative methods as well, and if that works, maybe you can then go back to your doctor and say, hey, maybe we drop, you know, the dosage down or
Yeah.
take this medication away altogether. So that was a little note I put also, just like never assume that something doesn't need to be communicated,
Yeah.
because the communication plays a big role in if they do try the alternative approaches or not. So number 2 theme was care coordination for alternative pain management approaches. And a big thing that I thought was unfortunate, one of the first things the authors said about this was that veterans generally had a negative experience with care coordination. So just basically how well, you know, different doctors on their sort of team communicate and coordinate their care amongst each other. I thought that was sort of an unfortunate thing to hear, although not that surprising, I would say, from some of the things I've seen in some of the bigger like hospital networks that I've interned with at some of our clinical experiences.
Absolutely. And I think, I don't know much about the VA, but I have heard like they have had issues like getting people in and like getting people treated.
Yeah.
Maybe it's because like the amount of people they are treating or they don't have enough staff or whatever, but I have heard before like that is an issue for them.
Mm-hmm.
So that's really unfortunate.
Yeah, I think as the themes go on too, they get more and more applicable to like physical therapy, like what we would do. So the first 2 themes are all about like getting them in.
Mm-hmm.
So it's like they have the knowledge, obviously. I mean, the study was looking at veterans who were seeking non-pharmacological help. So they knew about other options. It was just about like getting them there. So I think about it as veterans having the knowledge, and then once they have that, then it's about getting the access, which is like step 2. And then the third step, which is really on us, is the quality of the care. So as the themes go on, we could talk about that more, but I feel like theme 1 and 2 were more so not on the VA itself, but it really was like their not like responsibility, but them getting the word out more to the veterans. And
how
I mean,
the overall plan of care was like
right.
coordinated
Yeah.
and
yeah, so
given.
it was like that first step where the veterans had the knowledge, they wanted to seek non-pharmacological help, obviously. Then it was about getting the access, which there was like a bridge in the gap. So not everyone that had the knowledge was actually getting the access, and therefore not getting the quality. So I wrote that. I thought the same thing. Negative experiences with care coordination. One of the people they interviewed also said, I highlighted, I just decided to stick with one-stop shop because all my specialty care is going to be there anyway. So it wasn't like they just went to whatever was most convenient, and it might not have been the best for them geographically. It was about like 100 miles away. So that was another thing that came up as a pattern, was people like not being able to get to the place, or having to skip work and then missing out on pay and then having to pay for PT and then it not going well. So that's like more the quality aspect of it. But I thought the first two themes were more so getting the access, whereas the other three were more about like the actual quality of the care.
For sure. Yeah, and I think we sort of can make our way into that discussion in theme 2 in terms of being like an advocate for our patients. Like it comes up again, I think we'll talk about it more probably, I think it was theme 5 where it comes up sort of, but just that if you can tell, if you're treating a patient already and they're already on your schedule and you've been seeing them, if just by discussing with them, you know, at their visits that they're not getting the best coordinated care possible, like they're saying, oh, by the way, did you hear that thing from my doctor about my new medication? No, I've never heard. Like, take some time out of your day, take 10, 15 minutes to make some calls and, like, find out what's going on and put some pressure on, you know, other people to give you the information that's needed and help the patient get the information shared that they need to get the best care. So I think some of that can come on to us and we can take some ownership of that and help out with that as well. So
Yeah, another thing, like especially with this second interview where they talk about where the veteran, he called the VA and they gave him authorization for PT and then he called back to make an appointment and they said you don't actually have an authorization code.
yeah,
I think that's just like brings up another barrier to access to PT and other services. And I think especially for PT now, like the big push is for like direct access, which not just for veterans but for all populations just eliminates that barrier to access and could be a really strong point for us PTs as a profession, kind of like you said before, like doubling down on our strengths, like having that direct access and having the time spent with the patients, you know, that really makes our profession stand out.
right. Yeah, and we have to make sure that we are doing the most that we can to eliminate as many barriers as possible, because how easy is it for a person to walk in and get prescribed a medication? Like there are very few barriers to that. That can be a 5-minute, you know, process or interaction, whereas we need to make sure that we're making it as easy as possible for us to get these patients care with us that they need or that they could benefit from. So going into theme 3, like KP said, kind of transitioning more into specifically what we can have a direct role on. So veteran experience, or theme 3 was veteran expectations about experiencing pain. I thought this one was full of like great stuff.
The second sentence really nails it.
Yep.
Well, both quotes nail it.
Oh my God, that first quote's like incredible. So the first quote from one of the veterans interviewed was, she said, "Just teaching me how the nerve system works, how the brain works, the pain signals, your new life with chronic pain, that has actually reduced my pain a little bit. Just learning not to freak out every time I feel pain, it helps me to manage it better." I mean, that's...
You couldn't have like written that better, and that came from an actual quote.
Yeah.
Female veteran, pain now at a 4.
Mm-hmm.
So each quote has like the gender and sometimes their age, but this one didn't have their age, and then their pain level.
Yeah.
But yeah, this was awesome. I know me and you had the opportunity to go to like a behavioral medicine, it was called, around here as one of our clinical rotations, and that was big on like retraining your pain. This whole I forget the guy's name. What's his name?
Adrian Lau.
Yeah, Adrian Lau.
Yeah.
And him and Laura Mosley, another guy, who always talk about understanding your pain, and then that's like the first step to really controlling it. And this lady nailed it right on the head. I mean, literally, that has actually reduced my pain a little bit, just learning to not freak out every time I feel pain.
Yeah. Again, just learning, educating the psychological component to, you know, the neurological and sort of neurophysiological response to pain. I mean, those things are huge things in dealing with someone who has a chronic pain problem, and things that we need to talk more about. And that was like, I think, the quote that made me say like, oh wow, we need to do like a full episode on like Adrian Lau information and pain science and things like that, because it all boils down to kind of what was said there in theme 3 and what we talked about last week. Expecting suffering, expecting pain, like that expectation that you're not some helpless like person getting hit out of the blue by something, like an expectation, knowing something's coming and that you can deal with it, just alone
understanding
helps the process.
What it is, and you know,
Exactly.
it's not just like this nebulous thing.
Sheesh.
We should have a siren go off every time we use a word of the day.
But
But that's what the second quote was talking about.
Oh, yeah.
Was
Yeah.
and that we could read that too, but it's I like this one. We have instant remedies for pain everywhere. Everything is pain free, right? Even filling out a form on the internet, pain free. You want to apply for a mortgage, pain free. So when we start talking about pain, we have all kinds of messages coming to us about being free of pain. But we now have things like fibromyalgia and some strange things that are painful.
Yeah, that was another great quote
Yeah,
from
these
one of the
veterans are full of
participants.
great
I mean,
quotes,
yeah,
yeah.
they're really, it just goes to show like how much patients do know.
Yeah.
Like,
Yeah.
don't look at them as just some helpless like person who knows
Yeah.
nothing that you have to like baby through the process. Like, people want real information,
Yeah.
you know. Back your, you know, what you're telling them to do, back up your exercise prescription with some science and some
Yeah.
understanding, because people do appreciate that. And they know some stuff already,
Right,
like
right.
coming in. So, yeah, really great stuff there in theme 3, and I think a hugely important one to us as physical therapists. So theme 4, veteran knowledge and beliefs about alternative pain management therapies. So obviously, again, kind of tying into some of what we've already said, some of the points made under theme 4 were that some were already aware of the options available to them, whereas others were not aware that there were other options aside from the pharmacological means. So you do have some people still out there who don't have quite as much information and knowledge beforehand, and again, that's where that education piece comes in, and is important to let them know that there are other options out there.
Education, and even like things like marketing. You know, like the APTA has a like hashtag get PT first,
Mhm.
like push that
Choose
that they're
PT,
doing,
yeah.
choose PT. You know, I think that's really important to let people know throughout, you know, social media or whatever, going to places, going to marathons and stuff like we talked about, setting up tables, educating people on the fact that there are options besides, you know, pharmacology or whatever else that they might use,
Mm-hmm.
such as physical therapy, that has a huge potential to help them.
Absolutely. And so this is actually where that concept of like being an advocate for your patient came in. I was actually here in theme 4. So this was also a pretty disheartening quote that came from one of the participants. She said, "I went to physical therapy for a while. Nobody ever followed up with me to ask me if I was continuing that physical therapy program. But if you're going to have me do these exercises, I would expect that you would call me and make sure that I'm doing those exercises. Hold me accountable to it."
That's a great point.
So again, how long does it take out of your day to take 5-10 minutes
Yeah.
to call someone up, especially maybe right after they've gotten done, a couple
Yeah.
weeks out after therapy, and just see how they're doing, and like take a minute to show them that you care and that you're interested in them still doing well, even though they're not coming in to see you.
As like a buy-in tactic, that's so powerful. That
Absolutely.
they know that you care, and like they'll start to care as well if you perceive that they're not caring
Right.
as much or whatever.
So here's like an actual person who was a PT patient giving feedback,
Yeah.
and yet we're also having like these what's the word I'm looking for?
Adverse.
No.
Nebulous.
Just like requirements for efficiency. So efficiency numbers.
Right.
Okay, so
like
how-
high volume
Right.
clinics and things
How,
like
like, what did we just talk about in our business class last week? If you're working for 8 hours, you should be billing for 7 of those hours.
Yeah.
Well, you know, here's a part that slips through those cracks of those 7 hours that you're billing. Maybe spend a few minutes here and there.
that. Yeah, and I can imagine, you know, this patient might have been in one of those high volume clinics where
Yeah.
the PT might be seeing 3 to 4 patients an hour, and it has no time to spend with the patient or talk to the patient about their home exercise program. They're kind of off with the tech or whatever,
Mm-hmm.
you know, and that's where things like this happen.
Yep. Exactly.
And here we are complaining like, all right, not enough people know about PT.
Yeah.
Not enough people have access, and then we finally get one that gets access,
Right.
that has the knowledge, and then the quality
Yeah,
shit.
we like
So,
shoot,
like-
shoot ourselves in the foot there.
So like you got the knowledge, you got the access, you didn't get the quality, so now you're not going to have the knowledge anymore, and it's just going to like recycle
Right.
back. So originally I thought of it as more like a linear thing, but it's probably more cyclical in that patients that receive quality care will tell more patients, expand the expand the brand.
For sure. Oh,
Expand the
branding?
brand?
Hold on.
Are we managers?
Leaders.
Oh yeah, we're the leader. Well, you're the leader.
But again, for one fucking phone call.
Yeah.
That's what this woman wanted. She wanted one phone call to check in on how
Shit,
she
you
was
can even
doing.
text your patient. Be like, hey, are
Exactly,
you doing
yeah.
your exercises? Like,
Yeah.
it's not that difficult.
I mean, come on, dude. So, anyway, that was a big take home for me from theme 4. And then finally, the final theme that they came up with from the interviews was access to alternative pain management therapies. So, obviously, access is always a potential issue, but especially with alternative pain management therapies and just some of the barriers that exist both on the patient side and on the clinician side is what they talked about with theme 5. One of the big ones that they talked about within the article was just time as a barrier, and that was even on the patient end. Just talking about some of, the time they're taking away from their day to come in for therapies or, PT, OT, that could honestly be taking away money from them. One of the, I think, participants mentioned that, like, he has to take time away from work to come in, and that can, he can lose money from that in terms of how much he's making from his job. So there is a balancing act with some of that
I don't know how much we could do about that.
Exactly.
It's kind of like a priority thing.
Yeah.
Like, if you want to prioritize PT and get better, like, you're going to have to sacrifice something.
Right. So,
But then there's another quote that it was talking about the more physician side. I think they said
The only other option was a TENS unit.
well,
Well,
dude,
that too.
That quote came out of nowhere.
Yeah.
Like, I don't know where that quote came from, but it doesn't really fit into like the
Yeah.
flow of the article.
Well, this guy was crazy. He literally wrote laughs in his quote in caps. It just felt like if I bring pain to the doctor, like they expect to think, yeah, here's a pill, try this, so I don't bring it up.
So my theory on that quote, that's the chiropractic lobby right there.
Yeah.
Just throwing that in there.
Yeah,
Fucking
that's
bastards, dude. They do it all the time.
true. Yeah.
They're
Yeah, none of
powerful.
the authors
They're
were
powerful.
PTs, huh?
Yeah, I guess not.
But they did talk a lot about physical therapy, which
did.
is good.
Yeah.
The other thing I wanted to talk about was this quote was, I'm going to find someone who will solve this pain because obviously you cannot. So oftentimes doctors go, here, have a narcotic, have a nice day. And they have too much caseload to pay attention. So that's when the time aspect positively comes into our field, is that we have more time to spend with the patient about education, about just like understanding the therapeutic alliance that we talked about a couple weeks ago. Being with them for more time to not just say, here's our, well, obviously we can't say here's our narcotic, but here's an exercise, go do it. We have time to sit them down and explain that what their pain really is, and we can educate them on that. Some exercises for them to do at home, and then we can follow up some things eventually if they get discharged or whatever. So
Yeah, absolutely. All right, so we'll put that article up maybe in the details of the episode so you guys can check that out. Thought it was a really interesting article to get you thinking about some things about pain management, and hopefully we can have maybe another episode in a week or two on some of that stuff and
So
go even more into
one thing to wrap this up, actually, if you want to make an impact on these people, within the system, the military system, I went ahead and looked it up. Throughout all the major branches of the military, there are currently 189 physical therapists. So, and the average salary is $100,000. So, if you want to make a big impact, you do it in the system.
And it offers you some pretty unique abilities.
Yeah, so
within
that's direct. You have direct access.
Direct
you have
access.
the ability to prescribe some medications. You have the ability to order
Imaging.
and you're part of the triad. So you are a primary care physician within the military. So people, when they get injured, you could be the first one to see them. If like a physician's overloaded, they have too much on their caseload.
Yeah.
You'll be the first one to see them.
Yeah.
you could do that with TPT. You don't need any further education.
I don't think so. I think it's
You might need some.
Maybe like ComEd.
No, actually, it says military training. No initial job training is provided in this occupation. So I think you just, I could be wrong. I didn't look into that, but
definitely
pretty
something
awesome.
worth looking into a little bit
For
more,
sure.
especially with how much of a increasing need it is.
Yeah.
I think with and it also offers so many different areas of PT. Like there's obviously your typical musculoskeletal, orthopedic type stuff, but there's so much like neuro,
A couple of
amputee,
the interviews
concussion.
were amputees.
Yeah, traumatic brain injury. So there's
Yeah.
a ton of different avenues of types of treatment, types of patients you're going to be able to work with in that setting as well. So yeah, definitely. All right, so a couple things to wrap up the episode. We have a listener question. We are going to also talk about today's PT365 question live on air.
Never before seen.
Never before seen.
Never
What are we
done
going to
before.
call this? Do we have a segment name for this yet, or
Put it on the board. Right?
put it on the board?
You can put it on the board. Yes.
So put
Let's
it on
do
the
the-
board.
We'll do that first.
Yeah, well, let's do that first. So
Alright.
we do a board question from like PT365 app or some sort of app, textbook, whatever that we have. We answer it, talk about it.
This could be bad.
Could be.
It's
Could-
gonna be bad.
Could display. Could.
None of us have read it though. So.
Yeah.
All right. A physical therapist observes a patient exercising on a treadmill while monitoring the patient's vital signs. The patient suddenly develops shortness of breath and chest pain.
Mm.
After resting, the patient's symptoms continue and they develop a cough that produces blood-tinged sputum. The patient is most likely experiencing which condition? 1. Unstable angina. 2. Myocardial infarction. 3. Pneumothorax. Or 4. Pulmonary embolism.
I'm leaning towards unstable angina, but I'm not sure if we have
so the
group
two
consensus on that.
things were shortness of breath and chest pain that didn't resolve upon rest.
Correct. And then I guess you do have the sputum coming from
Sputum.
the cough,
So that could, yeah.
which
Ooh, I didn't think. Blood tinged sputum.
That's what threw me off.
That's
Yeah.
That's what it's throwing.
and that could kind of like start leaning me towards like a pneumothorax.
Or pulmonary embolism.
Yeah.
Because the
That's a
other two
final
are
answer.
MI.
Yeah, I don't think.
Like shortness of breath and chest pain. That's like an MI
Right.
sign. Or unstable angina is that's
Mhm.
like definition.
Right.
Sheesh. I think we got an advanced question.
Make the final answer, dude.
All right. KP, the phone's in your hand.
I'm not
Where we
gonna say
going?
it. I'm just gonna click one.
Okay.
And then
And can we put it on the board? Can I only say it if we get it right?
boom.
Oh, let's
Got it?
go.
See,
What
my
if-
thought process was along with yours, and
Okay.
I got it wrong.
Okay.
Pulmonary embolism.
Oh,
Yeah, so I went,
all right.
I went pneumothorax. I don't know. I thought their fucking lung collapsed and they're spitting
Right.
out blood.
I was
Okay.
thinking that, but I feel like that's there needs like a traumatic
Like
injury.
a puncture, right?
Right.
So, yeah.
All right, so let's.
Well, I
wanna
can. I
read
think
each.
3 different ways pneumothorax can.
You want to read like the
Should we just read
Yeah,
like
just
why
read
that
what the
one's
answer
right?
is, yeah.
why the answer is right or why the other ones are wrong too?
Why the answer is right.
All right. Well, I'll read the little thing first. A physical therapist must recognize and respond to signs and symptoms associated with emergent conditions. Early recognition can greatly reduce the relative safety risk to the patient. So pulmonary embolism is a condition that occurs when a thrombus loosens and travels in the circulatory system to eventually become lodged in the lungs. Symptoms include chest pain that may worsen with coughing or deep breathing, shortness of breath, tachycardia, a cough that produces blood-tinged sputum, diaphoresis, and syncope. Pulmonary embolism is considered a medical emergency and requires immediate contact with emergency medical services.
Mm,
So it basically just defined what a pulmonary embolism is, but
right.
I mean,
It's good to know about the blood tinged
Yeah.
sputum
Yeah, I've never
for
heard that.
pulmonary
Yeah, I've never heard
embolism.
of that
I haven't either. So shout out cardiopulmonary. Maybe we're getting to that next semester.
For done cardio.
Oh yeah.
we can sort of put it on the board.
Sort of. We got it right. So.
True.
All right. So we will wrap up today with a listener question. Our listener question
Where does this
comes
come from?
This comes from Bo Biggums
Bo Biggums.
down in
Louisiana?
Mississippi.
Oh,
I was
Bo
gonna say
Biggums from
Alabama.
Mississippi. Howdy, fellas. American by birth, Southern by the grace of God. Bo Biggums here. So my PT program allows us to offer or suggest clinical placement sites for our clinical coordinator to
That's
look up for
fucking
us.
luck.
Must be nice.
What do you guys look for in a clinical site? What should I look for? Can you give me any help on this?
That's a good question, actually.
That is a good question, Bill.
Yeah, what I've done was I've kind of looked at people in the field that I want to be in. So people working with like strength athletes, active adults, not necessarily just like athletes like high school, college, but even older people competing in CrossFit, powerlifting, things like marathons, whatever. Just active people that are going to be really engaged in the therapy process. And I've kind of sought out people that are really high level that, you know, produce content in that area,
Mm-hmm.
have like a big following on social media, put out, like I really just putting out good content, and like if I've met them before,
Yep.
like just talking to them to see what kind of practice they run and things like that. That's the most important to me. Just trying to find like a really good mentor that you'll actually like learn from, not necessarily just going to a random clinic hoping you get a good clinician.
Absolutely. Yeah, I think so. I think what that boils down to is whatever your main area of interest is, like seek out on your own information that shows you who are the best people in that niche.
Yeah.
So whether it's a specific practitioner who works at a particular clinic or a specific clinic as a whole, or if you're more, let's say, like inpatient oriented, who are the best hospitals? Like look up rankings. If you want to be a good therapist, you have to learn from the best therapists, be at the best clinics, see how they operate on a daily basis. So I think that's like a huge part of what you're saying is to go seek out those places and find them, and don't be afraid to like travel a little bit if you need to. You know, at the end of the day, this is setting up your career. So 6, 8, 10, 12 weeks of maybe, you know, living somewhere far away or whatever, making some sacrifices is worth it in the long run if you're at one of the top facilities or working directly with a really great practitioner.
Yeah, I think you should travel up to Boston, go to Champion PT. There's really only one answer. Mike Reinold is the only answer.
All right.
I think it depends like where along the like continuum of education you are. Like your first clinical, you might not be necessarily like specific. So if you find like a generic place that sees a lot of different types of patients, that's good.
That's actually great. Yeah, that's a good point.
And I mean, we talk shit on like these like production line companies, but like to be honest, the first one might not be bad to like get yourself into that type of thing, because they are common. You might like end up there, so it's good to have some sort of knowledge. Plus, like the high frequency and getting people in and out, it'll allow you to a lot of reps.
And lots of reps. Your timing, like with patients, with timing with evals and things like that. Yeah, it's a really good point.
But like your last one, I think you should look into specifics. Do a lot of research. Even like contact the person. Like what kind of patients do you typically see?
Yeah.
If it's like a neuro outpatient place, an inpatient place, if that's what you're interested in. But I think like along the education, you sort of find your own niche, and then during your clinicals, you sort of like wean things out even more, and then it eventually boils down to something that you really enjoy. So
great points. I think also too, like if you are kind of stuck and there aren't necessarily any facilities in the general vicinity around where you're from, you can even just if you know specific treatment techniques or types of treatment that you're interested in and want to see, you can usually go online and just search clinics, and they usually will include like what services they offer. So if you are interested in seeing like, let's say dry needling or ART or something like that, some of the Graston, some of those more specialty techniques or treatment options, or even neuro-based or pediatrics, you can usually go and find that kind of information online on companies' websites and specific locations of clinics. So
would you guys take a student?
Yeah.
Right away?
No.
Not right away.
No.
I've
How
thought
long?
that's
Like a
a
year?
good question too.
We'll talk about it next week.
Yeah.
I was gonna say
Spoiler, I would say like 3 to 5 is
Years?
where I'd feel comfortable.
Yeah.
No.
Just so like you're comfortable enough for like treating patients on your own,
Mm-hmm.
and then like provide a good educational setting for other students. You don't want to do them like a disservice and like be learning with them.
Yeah,
You know, you want to be able to actually like mentor them.
No.
Mhm.
My CI is 2 years out.
Yeah, last summer mine was 2 years out of school. There's some advantages to it as well.
He was pretty good though.
So pros and cons to anything. But yeah, maybe we can talk about that more. That's a good topic. All right, guys. Thanks for tuning in. Until next week. Next week, we have a classmate interview. First one. We're going to give you a little look into the lives of some of our other classmates and what brought them to PT school. So see you next week.